Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, and today we're talking about the affordability agenda for public health. Dr. Alister Martin is the new health commissioner of New York City. He joins Dr. Josh Sharfstein to talk about how the health department is working to advance Mayor Mamdani's vision of an affordable New York and inspire greater trust in public health in the process. Let's listen.
Dr. Alister Martin, it is great to have you on Public Health on Call. You are the new health commissioner of New York City. How is today going?
Josh, it's wonderful to be back on the pod, by the way. It's great to see you again and great to be in conversation with you. I'm doing great. It's just, as I've been sharing with folks recently, this is the best job I've ever had, quite frankly. I think that there's so much good that we can do for the people of New York in this moment that we're in with this new mayor, this transformative time. And so we're really excited to be able to push on some of the boundaries and try to do some transformative work in public health.
That's great. Now, we know each other in part because you've appeared on the podcast before, but could you introduce yourself a little bit to our audience?
Absolutely. So I actually was born and spent my early childhood right here in Queens, a couple miles up the street from where I am right now in our Long Island City office. I grew up in a place called Jackson Heights. My mom was a Haitian immigrant, and she was actually a nurse in a program that I now oversee, a program called Nurse Family Partnership. And my experience watching my mom growing up was, seeing my mom, pack her little gold Chevy with toys and playpens and puzzles for all the children.
Visits.
What's that?
A lot of home visits.
A lot of home visits, right. All the toys and playpens that she would take to the houses of the kids that she would visit. But I also saw her dealing with the realities of what it meant to be an at-risk pregnant person, many of whom were getting, letters home in languages that they didn't understand. And so what I learned from my mom in this experience was that, once you are connected to someone's problem, you have a responsibility to help them solve it. And that, for me, really is what I've taken through each and every phase of my life, whether that's being in the ER and taking care of patients as an emergency room physician and seeing the limits of healthcare, right? Seeing that for so many of my patients, we were limited in those four walls of the ER. And so that's what led me to start programs outside of traditional healthcare in public health, starting a nonprofit that became a national nonprofit, A Healthier Democracy. We created programs that addressed addiction for patients with opioid addiction, created vaccine access programs, created recently a program helping people to address the financial instability that's making people sick. That program is called Link Health. And then took those same lessons and that same skill set to government, working at the White House, working in state government, working in the federal government and Congress. And now really excited to bring all of those lessons back home to the city that I was born in and to do this work on behalf of New Yorkers every single day. So it's a real honor and a privilege, Josh.
Well, you've had an extraordinary career already. You're quite an innovator, and now you step into a large organization.
That's right.
It is historic. The health department in New York is known for all kinds of advances over the last century. What's it like, though, practically to walk into that office?
It's hopeful, man. It's hopeful. I feel every day walking in here that, none of this is settled in terms of the way that we currently do healthcare, the way we currently do public health. Of course, we're not unlimited in terms of our reach and our ability, but fundamentally, this is an optimistic era that we are living in, notwithstanding what's happening down there in DC and the federal government. Here in this department, we feel hopeful about the future of public health.
It's all about what can be done. You see a problem, you try to fix it.
Absolutely. And that's fundamentally because I think this department has come to the conclusion, and it came to this conclusion far before I got here, that no one is coming to save New Yorkers here, right? There's no federal government that's going to come with a plan. There's no global health public practitioner that's going to come with a plan. We have to solve our own problems here in the city of New York. And I think that there is this responsibility that every single one of the 7,000 public health practitioners that I lead comes into work every day believing it. And so when you have really great people on the team, you can't help but feel hopeful about the future of public health.
That's great. Now, you work for a mayor who has made affordability a key theme of his tenure. You mentioned that you started an organization that actually aimed to help with affordability for patients. How does that overall agenda affect your work at the health department?
Yeah, you can't have a conversation about affordability without talking about healthcare and without talking about public health, because ultimately the costs that are borne by our residents with regard to navigating the healthcare system, with regard to navigating what it means to be sick, routinely bankrupt people. Medical debt, for instance, is the biggest driver of personal bankruptcy in this country. And so that's just one example. But we are committed to really identifying what are the ways in which we as a health department can begin to address and engage with affordability. And we've come to 4 core problems that we want to do that work with. The first is around Medicaid coverage. Pretty soon, Josh, as you know, starting in January 2027, it's going to get really hard for folks to be able to keep their Medicaid coverage because of the new policy around HR1 and the work requirements and the biannual renewals. And so we are committed as a health department to making sure that every New Yorker who's eligible for Medicaid is able to stay on their Medicaid.
And that's obviously an affordability measure because Medicaid is so critical to providing access to healthcare affordably.
That's exactly right. And without health coverage, you have folks who are, essentially at the whims of healthcare prices, which is, as everyone knows, really challenging and opaque world. And ultimately being able to remain covered with reliable, affordable, and effective health insurance really, we think, is the baseline upon which you can build on the rest of the affordability agenda. But the second is around benefits. And it turns out, Josh, that in this city alone, there are over $2 billion a year that goes unspent because people are not doing things like enrolling in SNAP or LIHEAP or WIC or Lifeline, these programs which many New Yorkers are eligible for, but either because they don't know about the programs or the programs are too challenging to enroll in. And so we are committed as a department to helping connect those dots and help connect folks to those programs. The third is around evictions. We know that from the data, if you walk into that courtroom alone, if you're facing eviction, the vast majority of times you are going to lose that case and lose your home. But the data also shows that if you have a lawyer there with you, almost 80% of the time you're going to keep your home. And so many folks don't know that New York City is a right to counsel city, which means you have a right to a lawyer. So we want to also play that connecting role there. The last component, Josh, is around medical debt. I mentioned it at the beginning, but still the biggest driver of personal bankruptcy in this country. And we in this department have already erased over $135 million of medical debt. But there's so much more that we could do, both on the prevention side and on the side of erasure. And so that's the set of challenges that we've chosen to really focus in on as a health department. That won't be the end, but that's where we'll start.
Let me circle back to this question of benefits and evictions. And clearly, if people can get more money for food, more money for energy, avoid getting evicted, that's going to be better from an affordability perspective. That'll help them. How can a health department help with those things?
Really good question, Josh. And so first, you've got to build on what you already do. And what we already do here in the New York City Health Department is we already have sort of the seed of each of these solutions germinating on each of these 4 issues: on Medicaid enrollment, benefit enrollment, on eviction prevention, and on debt prevention and forgiveness. And so we already have a small amount of work happening. So the question is, how do we take what's working and scale it up rapidly? I'll give you a couple of examples. With regard to Medicaid enrollment, right? First things first, many folks don't know this, but we see over 500,000 patients a year at the New York City Health Department across our network of 11 clinics, our 3 huge neighborhood health action centers, and our vital records services. And so these are people who are in our spaces, interacting with our staff, and there are opportunities right there, right, to be doing the basic screening across each of these 4 components. But I'll double click on the Medicaid front. And so within our 11 clinics and our neighborhood health action centers, we have insurance enrollers because we understood a long time ago that having access to health coverage is the fundamental bedrock for being able to access healthcare services in the city. And so We've already committed those resources. Now the question is, how do we scale those up?
So, in other words, if somebody has a cold, they go to the clinic, they may suddenly find themselves being asked, hey, do you have Medicaid? Can I help you get Medicaid? But not just that. Maybe you're eligible for food assistance, energy assistance. And so what might start with a simple visit to the doctor could actually wind up helping someone in a whole bunch of different ways.
You got it. It's all about place-based interventions. And we're going to talk about trust in a minute here, Josh, but it's also about leveraging the trusted messengers that are already interfacing with patients on the day-to-day basis, right? Because what we know to be true is that in public health, you can only move at the speed of trust. And so our nurses, our physicians, our social workers, our community health workers that are already interfacing with patients, what we think of as an opportunity here is we can leverage those trust relationships to have this broader set of conversations around things like debt, around things like coverage, around things like benefit enrollment, and offer those staff tools and resources so they don't have to sit there and do the whole Medicaid application on their own. That's not the expectation. But the idea is, how can we start the conversation and then hand off, right? And we're looking at technology to be able to do that. We're looking at artificial intelligence to be able to do that. We're looking at call centers to be able to do that. But it's all sort of wrapped up in the same thing that you and I experienced when we were in our medical training. And that is that, if you're the provider on the ground, you only have so much bandwidth to really,
Right.
Address a couple of issues. You can't be expected to do a whole SNAP application and address the rental assistant and go get the person a lawyer. So what we're building here in New York City is, how can we help our staff have that initial conversation and then do a warm handoff right then and there in that clinic visit to an apparatus that can move the ball forward on these really important issues.
Got it. Let me ask you, the health department touches New York in many ways besides clinical services. One example might be restaurant inspections, or in other kinds of environmental inspections. Do you see that as a possible route to getting some of this information, or is it just for the clinical encounters that the health department has?
You nailed it. No, you nailed it as always, Josh. And we're looking at every single pathway possible. You nailed it. Yeah, we're seeing about 500,000 people in this sort of clinical environment, but we see people and touch people in these other ways. Our surface area is so much broader. I'll give you just one concrete example of something that we're looking at very closely, and that is, hey, look, we are every single year, right, helping thousands and thousands of New Yorkers get access to their birth certificates, get access to other types of vital records. What would it look like if you ever asked for a copy of your birth certificate, or when a new baby is born and a birth certificate is being sent home? What would it look like to use that as an opportunity to message about affordability, to get people to do that WIC application for their newborn, or to do that 529 application and get that young newborn into a college savings account, right? And so we're looking at every single one of these opportunities. And I think that's the fun part, the creative part of this, Josh.
Is there a policy element? You talked about medical debt and preventing medical debt. There are hospitals that, for example, send bills to people. There are other parts of the healthcare system that send bills to people. Is there an angle here about trying to change the ground rules and help people from, keep people from getting bills that everybody could pretty much figure out ahead of time they wouldn't be able to pay?
Exactly. No, exactly. And you nailed it. I'll give you just one concrete example, and that is around presumptive eligibility for financial assistance programs. So here's the example there. So look, if we know that you are on SNAP, or if we know that you are on Medicaid, okay, well, we should already presume that you are eligible for our financial assistance programs if I'm a hospital or, safety net provider. And so unfortunately, many hospitals don't have this kind of presumptive eligibility process, and they leave it up to the patient who's already sick, who's already short of breath, who's already there with chest pain, to have to think about, how do I fill this application? Go ahead and find this application and then submit it. So some laws, some states across the country are doing a lot of really, really good work around this concept of presumptive eligibility. If we already know you're on SNAP, boom, the hospital takes care of the financial assistance and medical charity process on your behalf, so you don't even have to touch a single piece of paper. So that's one of the examples. There are many others, but that one I like a lot.
So you are thinking creatively about all the different ways the health department can help make life more affordable for New Yorkers and protect them from bills that they can't pay and could actually ruin their credit or push them into bankruptcy. How do you think this might affect how people in New York relate to the health department over time?
Vision of the future of public health that we're trying to create here in New York City is simply where the service is the message, Josh. The service, the way that we address the key challenge in the life of a New Yorker. That is the message. I think that public health has a trust problem. If you look at the data, public trust in public health institutions dropped from the 50s pre-pandemic to the low 30s, right? And so we are in a trust deficit with regard to how folks think of us here in public health. I don't think you can communicate your way out of a trust deficit. I think you have to serve your way out of a trust deficit. You have to earn your way out of it. You have to show up in people's lives and demonstrate to them that you are helping them to solve their problems. And so this is the vision of the future of public health that we're creating here in New York. And the reality is, it's not anything new, right? Where did public health start from? Public health started from addressing the sanitation issues that were making people sick in a very visible way, right? And so, at least here in New York City. And so I think that there's an opportunity to go back home to those roots of directly serving people.
Really delivering.
Really delivering. You got it. And so, I think that, we want to be seen showing up, delivering for folks, making sure that they understand that we are here for them and working on their behalf. I'll give you one more piece on this, and that is that we often think of ourselves in public health as the invisible shield. And I take issue with that. It is one thing, and it's a very important thing to be a shield and to protect people and to defend them. Very important. But what happens to things that are invisible? People often neglect them. They take them for granted. They don't think of them. What happens next? Well, when there are funding cuts that need to happen, when there are things that need to be defunded, when there are budgets that need to be, quote unquote, right-sized, okay? What's the first thing to go? The things that are invisible, the things that have been taken for granted, the things that folks have sort of written off. And so I think that we have to do a better job demonstrating in a visible way the way that we show up for people and the way that we care for them and the way that we make their lives better. And we're glad to be at the tip of the spear of that. I'll tell you one other thing, Josh. We're not alone. You look around at public health right now, there is this movement that's happening all across the country to make the work that we do more visible. And I think on the end of that movement, we're going to have a completely different public health ecosystem. And I'm so excited for that future.
Well, I very much appreciate that vision. Dr. Alister Martin, New York City Health Commissioner, thank you so much for joining me today on Public Health on Call.
Thank you so much, Josh. Take care.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.